Hello everyone, my name is Dr. Love and I'm one of the Hematology Oncology Fellow, and today we will talk about transfusion associated cardiac overload, TACO. So let's start with a scenario. A 78-year-old woman who already has a history of HFrEF and CKD come to the hospital with symptomatic anemia. You notice her hemoglobin came 6.5 and you decided to give the 2 units of pegged RBC in this patient. After she got the first unit, now she is in the second unit of the transfusion, and 30 minutes after the second unit, she developed high blood pressure. Her blood pressure goes to 178 over 95 millimeter of mercury. Her heart rate jumps to the 120. Her oxygen saturation come down to 88%. And then you also notice the elevated JVP in this patient, and then you do the auscultation. On auscultation, you hear bilateral crackles with audible S3 hard sound, and then you order a chest x-ray. In the chest x-ray, she has bilateral pleural effusion, which is pulmonary edema, and enlarged cardiac salivate. So what is their diagnosis? So this is transfusion associated cardiac overload. So let's deep dive into the TACO. So TACO normally happen within 6 hours up to 12 hours after the transfusion. And in this patient, the important stuff was high blood pressure, high heart rate, and the signs of volume overload like jugular venous distension, S3 heart sound, and cardiomegaly. And when you will order the pro-BNP level and anti-pro-BNP level, it will also be elevated. So what you do, you remember from my previous videos, the first step is to stop the transfusion. When you stop the transfusion, you can make the patient sit upright and you can put the supplemental oxygen for the patient if the patient has low oxygen saturation. And after that, you can give the patient IV loop diuretics like furosemide, which is also called Lasix. Why it is called Lasix? Because it has a 6 hours of the half-life. You give Lasix if the patient's symptom improves. That means you were right. It was transfusion associated cardiac overload. So who are the patients who get these reactions? So those patients who has a history of heart failure, CKD, on dialysis, or extreme of age like very young patient or very old patient, or those patients who get fast transfusion or multiple units of transfusions. So how you can prevent these kinds of reaction in the high risk patient? You always give a single unit and then you reassess the patient before giving the other unit, and you also slow the transfusion rate. Mean you have to give the 1 unit of pegged RBC for 3 to 4 hours, and you can also give pre-transfusion diuretics to these patients. In the next video, we will talk about TRALI, transfusion associated acute lung injury. And the question for you guys, which patient need leukoreduction of blood and which patient need washing of the RBC?